And
Good.
obviously, socially, we are missing meeting each other, but certainly this virtual concept has really helped us get in contact with people like yourself across the globe who are specialists in certain aspects of arthroscopic work, and really it helps us because as I mentioned earlier, evidence is very little. So, we rely a lot on experience-based, topic-related information. So
We are live, sir.
Good.
Perfect. I think, good, Sandeep. Thank you. Good evening. Welcome, friends, to Indian Arthroscopy Society webinar today. Throwing injuries, especially in athletics, are something which is a big dilemma for all of us as a sports physicians and shoulder specialists. Dr. Jeffrey R Dugas, who is director of the ASMI Sports Medicine Fellowship Program, and his partner in Anterior Sports Medicine and Orthopaedic Center in Birmingham, Alabama. He's an authority in athletic shoulder, and he's with us today to discuss more on where are we today on this interesting topic. Dr. Shreyash Gajjar will briefly introduce our speaker today, and then all his presentation. You can send your questions on YouTube chat box so that we can ask the question to the panelist as well as to the speaker, and then you can have all your queries sorted out. Dr. Shreyash, if you can please introduce Dr. Jeffrey to all of us.
Yeah. Thank you, Dr. IPS Oberoi, and hello everyone, and welcome to this Master Series webinar on the athletic shoulder. Where are we today? Shoulder injuries are common both in the contact and non-contact athlete. However, controversy with insufficient evidence still exists regarding the optimal treatment of an athlete. This is when eminence-based rather than evidence-based approach helps. And today our Master Series speaker is Dr. Jeffrey R Dugas from Birmingham, Alabama, USA. He has a special interest in throwing athletes, and much of his research is centered in this area. He treats all types of orthopedic sports injuries, including injuries of the shoulder, elbow, and knee. He completed his orthopedic surgery residency at the renowned Hospital for Special Surgery in New York City, following which he did his orthopedic training and subsequently a fellowship in sports medicine at the American Sports Medicine Institute in Birmingham, Alabama, which is a world-renowned center under the direction of Dr. James R. Andrews and William G. Clancy Jr. He was thereafter invited to become a member of the Alabama Sports Medicine and Orthopedic Center. After its dissolution, he became a partner in the Andrews Sports Medicine and Orthopedic Center. Additionally, he serves on the board of trustees as the American Baseball Foundation and the American Sports Medicine Institute, where he conducts research and serves as director for the ASMI Sports Medicine Fellowship Program. He also serves as an associate medical director for the Worst Wrestling Entertainment, WWE. He has published extensively both articles and textbook chapters related to injuries of the shoulder and elbow in throwing athletes, vascular injuries in throwers, and rotator cuff injuries, to name a few. He has also published manuscripts on the treatment of knee ligament injuries and the treatment of cartilage defects in the knee. He holds membership of numerous prestigious societies and serves as a team physician for a number of high schools. He has also been named one of Birmingham's best doctors for 8 consecutive years and was selected by his peers as one of the top orthopedic surgeons in the state of Alabama. Also, personally, he has been a baseball player in his younger days. So really, the Indian Arthroscopy Society is privileged to have someone as experienced as him on this topic. And I would like to invite him to kindly share his talk and give us his views on the athletic shoulder. Where are we today? Thank you.
All right. Wow, that's a lot, and I appreciate the opportunity, Dr. Gajjar and Dr. Oberoi. Thank you for having me, for the whole society. Thank you for allowing me this time to share with you. I've got to go back to the top of my talk. We were checking videos, so let me go back to the top here. There we go. So here's the top. So thank you for the opportunity. I'm honored by the invitation, and I sincerely wish I could be there in person. And I look forward to the time when I can be there in person. I disclose, and we disclose our relationships, our financial relationships. So I am a consultant for Arthrex. I receive a royalty for products I help design, and ASMI receives research and education support from a number of places that we are very appreciative of, allows us to continue to do the work that we do. So our goals are going to be to discuss the treatment of specific conditions that are commonly seen in the athletic shoulder. We'll touch on, mostly rotator cuff and labral stuff, but we'll hit a couple other things just briefly with a couple of thoughts. This is a big topic for 45 minutes, so I'm going to try to stick to the stuff that's germane to what we all see every day, and try to hit on some little things as well. So we're going to discuss, I'm going to try to separate the things that are different between how we treat the overhead or throwing athlete and the non-overhead athlete or the contact athlete, and what the differences are in general terms. So some general comments on today's surgery. Things are definitely going soft. We are using mostly soft anchors for our rotator cuff repairs, our labral repairs, remplissage, ligament repairs, meniscal repairs, all these things. We've really gone towards soft anchors with a significant increase in the use of knotless anchors. There's a lot less superior labral surgery. We're moving more into biceps tenodesis than slap repair, particularly in the non-throwers. We're still doing slap repairs in the throwers because biceps tenodesis just has not caught that in terms of success rates. There's a lot more bone augmentation going on in shoulders, more Latarjets and distal tibial allografts being done for instability. In my opinion, these are being overused. These are very complex operations that don't need to be done by everybody. I think they're good for failed primary repairs or when there is bone deficiency, but I don't think that they need to be used for primaries. So here's some of the soft anchor technologies. These are things that we use every day. These things have great holding power, and they're easy to use, and they don't create problems within the joint. And we'll get into that later. So throwing, as you can see, I challenge people to see if they can put their arm in this position. I certainly cannot. I think you'd have to operate on my shoulder if you found my arm in that position. But this is what throwing does, and it leads to incredible stresses across the shoulder and the rotator cuff, the labrum and the capsule. It is purely an over-rotation phenomenon, and people have to develop this over time. This is not something you're born with. So for internal impingement, which is that combination of over-rotation, posterior translation, and kissing up there between the superior posterior labrum and the undersurface of the rotator cuff, we typically want to debride or repair the partial rotator cuff injury, debride the kissing lesion, and repair or debride the slap lesion. There were times in the last 20 years where we were repairing all of these things, and we found that we may be over tightening some of these people. And so these are purely overuse injuries. And I have to thank Will Ferrell and the movie Elf for doing this video. This was one of my favorite movies, but it's also a great video that demonstrates overuse. You just can't throw that much. If you throw a lot and you keep throwing and you keep throwing and you keep throwing, you're going to develop some problems in your shoulder. So partial thickness rotator cuff tears, these are a more common source of pain than we previously thought. They're not a singular condition. And that's because partial is a really big word. It contains a lot. It contains everything from a little bit to a lot, which is a big spectrum. The results from a variety of insults to the cuff. So it can be intratendinous, they can be bursal, they can be articular. So there are different patterns of failure depending on the type of injury that the person has. They're definitely more common on the articular surface, and they do not heal spontaneously and typically progress. So these are kind of bad actors in terms of things we see in the shoulder. Very well-known surgeons from around the globe have kind of heralded the fact that these are a problem. You can see degrees of delamination. The fibers demonstrate retraction. Some tears extend into the depth of the tendon, dissecting into multiple layers. Gilles Walsh told us that. Fukuda told us that spontaneous healing is unlikely. So these are bad problems. Intratendinous tearing suggests the presence of shear within the tendon. Shear is not a good thing in the body in general, certainly not in articular surfaces, but also not in tendons. It creates all kinds of problems. And when we've dealt with these things in various ways over the last 20 years, we've found that maybe we haven't been as successful as we had hoped. Debridement works some, repair works some, and I would tell you that we're really still struggling to have a solid answer as to what is best for some of these things, and they're really individual. So MR arthrogram continues to be our gold standard of imaging. Here you can see a typical, 2 or 1.5 or 3T image. We usually typically look at the sagittals and the Aber views to see what the rotator cuff looks like. And the addition of the intra-articular contrast really does help identify some of the pathology and makes our preoperative planning easier. So MRI continues to be the gold standard. Ultrasound simply cannot tell you some of these things. And so while ultrasound is convenient and easy, MRI continues to be the gold standard. So what about debridement? Well, I mean, for something like this, where we all see this kind of minimal undersurface fraying, this is not big pathology, but for a thrower or an overhead athlete, this might be enough to keep them from throwing. This is the kind of thing we want to shave, right? We're going to put a shaver in there. We're going to smooth this down. There's no way we could put a stitch in this and repair it. If we do advance that stuff, we're probably going to over tighten the shoulder. And I would say this represents well less than 25% of the thickness of the rotator cuff. Certainly an ideal one for debridement. You would expect this person to do well. You look in the background, you see the biceps tendon looks healthy. There's not a lot of inflammation in the shoulder. This is one that will do well with simple debridement. So spontaneous healing is not likely to happen. There's no synovial layer. They're hypovascular. They will continue to impinge. So is it worth doing a subacromial decompression for any overhead athlete who has labral pathology? That's a fair question. In my opinion, if I'm operating on the rotator cuff of a thrower, even if it's for simple debridement, I want to go up above the joint. I want to look in the bursa and make sure there's not compression up there, and make sure that this rotator cuff is not taking stress from both sides of the equation, from both the joint and from the subacromial space. I certainly don't think there's any harm in doing a simple decompression. We would not take a lot of bone on the acromion, but we want to make sure the cuff is not taking it on both sides. So we looked these up. One of our former fellows, Scott Reynolds, looked these up, and we published this in Core in 2008. Only 55% of professional overhead athletes return to the same or higher level of play after debridement of a partial thickness rotator cuff tear. So I think it depends heavily on the degree of partial injury. And as I said, partial is a big word. It's a big spectrum. It's not just one type of injury. I think if we could subdivide these, we would see that lower grade, lesser injuries have better outcomes than higher grade, more severe injuries. Repairing partial thickness tears, Rossi published in Arthroscopy in 2019, 80% of patients were able to return to full activity, but these were average age 42. These are mostly recreational athletes. These are not high level athletes. But about 80% were able to return at a mean of just under 6 months. 80% is good, but not great. Klusch in 2016 did a meta-analysis of 25 studies that showed 85% return to play with all patients, but only 50% of high-level athletes were getting back. So what all of these studies show us is rotator cuff disease in overhead athletes is still a bad thing. The outcomes are not great. We can't count on tremendous rates of return. So what are some options in terms of what we can do? And could we do less rather than more? Maybe doing less is a better thing. Taking these things down and repairing them as we would a full thickness tear is probably doing more harm than good. So what if we get this kind of undersurface tear with extension, at the supraspinatus, infraspinatus junction? This is typically what we see in throwers. This thing's gonna, extend. We want to try to maybe pull this flap back or sew it back to the superior lamina. So that dotted area represents the extension of the tear in between the two lamina of the tendon. So one option would be to put a couple of sutures in here and try to pull this back together. So this can be done all inside through a cannula with a passing device like this. You can see I'm going to put the cannula, the passing device through the posterior limb, and then grab it through the anterior limb. And we're basically going to pass this and place a stitch there and tie it down. And you're going to get something like this. So this is a minimally invasive way to pull this back together. I'm not trying to advance the cuff too much here. I don't want to really pull it up. If I advance the cuff, I'm really not going to be able to throw. These things, if you over tighten this and pull up that recess and pull up the capsule, you're really going to inhibit their ability to throw. So the placement of these sutures is very important where we place them. So when I've tied that back, now I've kind of tied it side to side. I've not really advanced it very much. And now what I need to do is close the gap between the inferior lamina and the superior lamina. So I know that there's a space in there. This is not likely to heal because it's articular, it's synovial. So I want to place some sutures through here like this and get these things to heal superior to inferior. So I'm using these small little needle graspers through the cuff. I'm working inside. I've already done a decompression, so I'll be able to see up top when I need to go tie these things up there. So I'm going to pass a couple of these sutures through there and tie these things down so that the lamina are compressed together and have a chance to heal. And then I'll tie these up in the subacromial space. So the articular side is closed. I've got that all closed down from where we started. I've closed that all down. And now I've got these sutures up in the subacromial space that I can tie. So we tie those down there, and this is what the final result would look like. So this is probably the best I can feel about something like this. I think if I tried to take this back to bone, I would be advancing it too much, and that probably would not go well in a throwing athlete. In a non-throwing athlete, I would have no problems debriding it. I would have no problems putting it back to bone because they don't need that finely tuned rotation that a thrower or overhead athlete would need. So here's a case example. This is a volleyball coach, non-dominant arm. So she's not going to hit. She's not going to have to hit with this or perform an overhead throwing motion. She had 2 years of symptoms, failed repeated treatment non-operatively, and her MRI looked like she had bursitis. So here's this undersurface tear. And when I debride it, she's got about a 50% thickness tear, about 5 millimeters thick, 40, 50%. She's 39 years old and she hurts. So, I can't repair the tissue that's frayed. So I trim that out. And now I'm going to advance this back because this is her non-throwing arm. I can repair this and she's not likely to suffer any inability to do her job. So I'm using these two all suture anchors. These are little 1.5, 1.6 millimeter anchors with a high grade suture tape or fiber wire or something like that on it. And I can again use these needle passers through the cuff. So I'm not making big holes in the rotator cuff, and I'm transitioning back and forth through my anterior portal. And I can pass these through the cuff through that undersurface lamina. So I'm trying to pull that lamina back to bone. I've created a bleeding surface, which is important. The biology of healing has to happen. So I need that bleeding to come from the bone. And I can tie these things up in the subacromial space. And you can see we've pulled that undersurface lamina back to the humeral head. In a thrower, I think this would be too tight to throw. But in a non-throwing shoulder, this is a really good technique. She went on to do very well and has not had any pain. I did this a couple of years ago and she's been fine ever since. So for full thickness cuff tears, these are rare. We usually don't see full thickness cuff tears in thrower unless they're younger and they landed on it. They usually have associated instability. Full thickness attritional ruptures are particularly bad. These are poor quality tissue that's weakened over time. These are generally poor outcomes in throwers. We want to repair back to bone when we can and intrasubstance when we have to, but there's a real emphasis on PT. We want to get motion back because motion is so important to throwing, but we don't want to put a lot of stress on the repair. So this is a case I did earlier this week. This is a 14-year-old, if you can believe it. This kid is also a football player. He plays American football. So he fell on his shoulder. This is his throwing arm. He's really a primary baseball player. He's a good sized 14-year-old, but he has all this inflammation in his shoulder. His biceps had some fraying to it. And he's got this undersurface tear where he avulsed off some of the undersurface lamina of his cuff. When I look from front to back, so the previous picture, I was looking from back to front, looking at the biceps. I switched the scope around and I'm looking at this big hole in his infraspinatus, kind of the junction of his supraspinatus and infraspinatus, this big hole in the back side of his shoulder. At first, I thought maybe I made a really aggressive portal, but that's not the case. This is actually the tear that the kid had. So he has a good sized tear. This is the look from the subacromial space. This is a big tear in a young kid. And so bad bad actor here. This is not a good thing from a throwing perspective. So I passed some sutures in. I wanted to close the capsule down. He doesn't really have any labral pathology, no significant instability pattern. So I closed the capsule down with that, and I put 4 or 5 stitches, and I put a couple up top to close over a flap that he had created up top. And that was the final repair. Hopefully in a year, I'll be able to tell you that this kid did well, but I suspect that throwing is going to be difficult for him. So full thickness rotator cuff tears in athletes have a particularly poor outcome in overhead athletes. One of our fellows, Chris Mazaway, did a nice study in 2016 where he looked up the rotator cuff repairs we had done, and only 1 out of 12, 8% of professional athletes in the overhead world were able to return to the same or higher level of play. So that's pretty bad outcomes. Maybe with newer techniques and lesser invasion and doing some lesser procedures, we may be able to do well, but there's not enough data available right now. This is the best we have. So I would tell you that a full thickness tear in a throwing athlete is a pretty poor outcome thing. So let's move on to some labral stuff. It's football season around here. American football has started. College football is back, and the whole country is getting a little bit of a lift around here because the baseball playoffs are going on. The basketball playoffs are going on. College football has started. The NFL has started. So this is a really exciting time sports-wise in the United States. Type 2 slaps are really kind of the hallmark of overhead athletes and they represent the largest dilemma in terms of treatment. These are typically easy to find on exam as well as on MRI. Contrast MRI, arthrogram MRI is still the gold standard. This is a pretty typical appearance where you can see the contrast extending up under the biceps. This is not simply a sublabral foramen. You can tell that the tissue is clearly detached from bone. So we talk now, this is kind of a new concept over the last, I'd say 5 to 7 years, the difference between a good slap and a bad slap. A good slap is adaptive and allows the external rotation that the thrower needs. Maybe these people, when they were 5 to 7 or 10 years old, didn't throw enough to get that external rotation they needed later in life to be good throwers. So that adaptively, they've kind of peeled their labrum off over time. These are chronic things that have existed really since they were children. There's no acute finding to suggest recent trauma. We do not want to repair these things. They may look meniscoid, but when you get in there, they don't look like they're acute injuries. And if we repair these things, we're going to over tighten the shoulder and they're not going to throw. That's very different from the bad slap. These are traumatic, previously healthy tissue in an overhead athlete or non-overhead athlete with good glenoid attachments, and there's evidence of a recent trauma. These are the ones we want to repair back, and we want to use a lot of points of fixation to get good compression. You want to avoid constraining the biceps, and you want to avoid pulling up the capsule in the superior recess. That capsule down there and superior to the glenoid is really kind of a danger zone. If we pull that up too much, you really over tighten these things. So surgical technique is particularly important here in terms of not over tightening it. So here's our kind of wizardry of slap treatment. Type 1, we debride. Type 2, we stabilize if they're bad slaps. Type 3 and 4, you're going to excise the bucket and stabilize the labrum. And if you're getting into bigger tears, you're probably not dealing with a thrower. So we do all of our shoulder stuff in the lateral position. You can see here, they're in an arm holder at about 45 degrees, slightly pronated or slightly protracted. We're on the back side. We've usually got a pretty large surgical team. We insufflate the joint with some saline, and then we make our portals anterior and posterior to start. We'll make a lateral portal when we're doing something in the subacromial space or dealing with the cuff. So this is what I would consider a bad slap. You can see the inflammation in the shoulder. This was clearly a well-attached labrum. This is not one of those things that has been there for a long time. This is a traumatic injury and should be fixed. Same idea here. This is one of those things that's off. I've already debrided the bone. I think bone debridement is super important in these areas. The labrum is a tissue with very poor blood supply. It doesn't like to heal. If it wanted to heal, it would have healed before we got here. And so I think creating that biologic environment for healing is very important. And that only happens by getting into the bone. I frequently say the labrum does not heal to the bone heals to the labrum. And same thing with the rotator cuff. The tendon does not heal to the bone heals to the tendon. So this is a particularly interesting slap. This kid has a, I think this is a type 4. He's got a big bucket handle tear, and you're going to see here in a minute. And I'm not going to spend a lot of time on this video. The point here is these can be pretty bad injuries. So once we get the blood out of the shoulder, I'll show you the technique here. We are using a shaver to shave out the big bucket handle here. This is obviously traumatic, big injury here, lots of inflammation. So you can see this big, probably type 4 slap. And then we really want to get into the bone and really make sure we get a good bleeding surface. So this requires a lot of very careful attention. I don't want to go scarring across the cartilage. I try to use small cannulas here, so I'm not going through the cuff. This is a curved cannula that I can insert a 1.5 millimeter anchor. And I want to put this thing back right where it came from. I don't want to advance it. I'm not trying to roll that whole remaining labrum up on the glenoid. We're using all suture anchors. When we do these, we're going to use a solid drill. These are nitinol drills, and we're clearing all the bone debris out. This is actually what's called a Juggernaut Anchor. I've really gone more towards the fiber tack, suture tacks that are a little bit better, I think, in my opinion, than these, and also the knotless ones. So I'm going to shuttle back and forth with different instruments, and I can pull this out here. This is a knotted anchor that I'm using, so we're going to tie knots in this one. And I'm showing this because I think it's really important where the knot stack goes. So the knot stack really needs to be off of the glenoid, off of the shoulder. It needs to be off the glenohumeral joint, because those knots can really become a problem. So I want to make sure as we tie this down that we get this knot on the back side, and that it is not sitting down there in the joint. And so as we pull this down, I'm going to make sure that my post is the one that is superior. I'm going to use a lot of different points of fixation. As you can see, I don't want those knots up on the articular surface. So I'm going to get a whole bunch of different points of fixation, and I'm going to advance this a little bit so that we can move towards where the final product is here. But you can see here that biceps is really diseased too, where the tear was. So I've got to try to pull this down. So now I'm working from back to front. I think it's easier to work back to front on these. So I want to get this at the base of the posterior aspect of the biceps. I don't want to over constrain the biceps here. So I'm going to keep going here with these anchors, and I'm going to pull this in, get this one looped down, and try to tie on the back side. So I got that off the joint. Now I've got one in the front here. I want to tie this down in the front. And then I'm going to try to get this one last one here. So I pull this big flap of biceps down. But I really got to be careful because I can over constrain the biceps here. So I really want to be careful how much tissue I take. I don't want to overdo it. And I'm going to pull this down and just try to pull that tissue back to bone. So in the end, we're going to see this is what the repair looks like. And whether or not this person is going to get back to throwing is definitely a question. This is a really big injury for a thrower, even though it's just a slap lesion. Certainly biceps tenodesis could be considered here, and maybe today we would do that kind of an operation rather than this. I can't tell you that I remember whether this guy got back to throwing or not. So what about the biceps tendon? If a slap repair is not the best option, would tenotomy or tenodesis be an option to relieve pain? In non-throwers, we utilize a mini open subpectoral and zone 2 biceps tenodesis. We use a 5.5 reamer at the bottom of the intertubercular groove, just above the pallium pectoralis, and we fix it with a 5.5 millimeter peak interference screw. That's kind of become our standard, and we're doing a lot of these, particularly in the presence of rotator cuff tears, non-throwing shoulders, things like that. So certainly in a non-thrower, non-overhead athlete, this is a good option. What about the instability thing, or an anterior labral tear in a throwing athlete? So, what if we get something like this? You know, this is a really good baseball player who lands on his throwing arm, dislocates his shoulder. Meanwhile, the guy's running around the bases, but his shoulder is out. He's got a dislocated shoulder. This was Ken Griffey Jr. dislocating his shoulder as he dove on it. You know, this is a bad injury in a throwing shoulder. And then there's others. This is Kenny Lofton, who played at the time for the Reds. I think he was with the Indians, actually, but just sliding into base. And if you're a baseball player, your coaches will tell you not to slide into first base. But, you know, Kenny was an elite outfielder. And so he slides in and he subluxed or dislocated his left shoulder. That was his throwing arm. And he was out. So, you know, what are we dealing with here in an overhead athlete? So in an overhead athlete, we certainly want to do these things arthroscopically. When we're dealing with the anterior instability in a thrower, you got to do these arthroscopically. If we open them, they're not going to throw. They're typically big tears because it was a lot of trauma to get the shoulder out. In a thrower, these guys are usually diving in some way or landing on it. So big injury. This injury actually goes all the way around to the back. The tissue is good. It's good quality. This is a relatively acute tear. Again, we just want to put it back to where it came from. We want to make sure we get the bone bleeding, get a good surface for healing, get good biology at the interface, and get that labrum to stick down. So we're going to use lots of points of fixation. We're going to try to go one anchor about every clock face number and get this thing to stick down. So I'm going to advance here a little bit. So we're going to start putting in anchors. You can see I've got this elevator. I'm just getting it in there. I'm going to put a shaver in there and really go to town on getting the, you know, breeding out the stuff, but getting the bone bleeding. I want a great surface for healing. So I'm going to try to get down to bone and really get bleeding happening so that this thing can stick down. I think this is one of the more important parts of the operation, is just to get a really good surface for healing. Then we're going to make our anterior portal that's through the subscap. So I'm going to have to get pretty low here. So I'm going to make a second anterior portal so I can work up there. And using a curved cannula, I'm going to be able to insert an anchor down there at the 6 o'clock position. So we're going to make this second portal up here just over or through the superior border of the subscapularis. That's going to give me good access to putting in these anchors. These are these all suture knotless anchors that we've been using. I really like these anchors. They're great holding power. This is a curved cannula, so I can really get a good angle to the inferior glenoid. I can have my assistant holding the arm, and I've got a great angle to put my anchor in. So we're gonna keep going and put this first anchor in down at the inferior portion. I try to start down here. This is right at about the 6 o'clock position. So I think this is the most important anchor, and that's why I do this one first. From there, I can easily move up. It's tougher to move down once you've got that anchor in place. So here comes our soft anchor. You can see the little loop there as it goes in. This is a knotless anchor, so I'm going to pound that in. And when I pull the driver off, I can leave the cannula in there because I've got two spots, or I can pull it out and replace it. I'm now going to use a passer. You can see I'm pulling on this thing pretty hard. I'll basically be able to lift this guy off the table. It's not going to come out. These things have tremendous holding power. So I'm going to use a wire passer or some kind of a loop passer here. This will pass just a plastic or a nylon loop into the joint, and I'll be able to pull up some labrum to get this thing to go back. So basically, I've got a good view here. I'm working through my second anterior portal, my trans subscapularis portal, and I'm going to pull this up here. I'm going to get under the labrum. I want to make sure I go under it, not through it. Advance my wire in there, and then I'm going to pull. I'm going to go through the loop and grab the repair stitch. So the repair stitch is the blue and white one. So I'm going to grab the repair stitch, which I'm then going to pull back through the tissue using the black wire. So I'm going to pull my device out here. This is going to go through the labrum, through and around the labrum, and I'm going to have my repair stitch. Then I grab the smaller of the two pull stitches, and by doing this, I think I just started over. Maybe not. So did I just start over? Yeah, so I grabbed the smaller of the two pull stitches. One is shaped like a tape, one is shaped like a suture. So I want to grab the suture one and the repair stitch, the blue stitch, and I'm going to pull those both out. And basically what happens at this point is we're going to, outside the shoulder, I'm going to place the repair stitch through the loop that's in the pull stitch. So this comes with a pre-made loop. I put the repair stitch through here. These are both out through the same hole in the capsule because I pulled them both out together. So I put this down to a little purple mark that they make for us. And then I advance this using the other pull stitch. So the tape stitch now I pull, and this advances the repair stitch down through the anchor, creating a knotless construct. So I can pull this down there, and then all I have to do is pull the repair stitch, and I've got a knotless repair construct. I don't have to tie any knots. This is a really strong anchor and a really good pull-out strength, and I can march up and around the glenoid with these and get a terrific repair. So this is kind of our standard these days. We've been doing this for a few years. I'd say we started using these anchors about 5 years ago, and now they've become kind of our general everyday anchors for basically everything labrum. So we'll march up the glenoid here, and we'll put these things everywhere. We'll just keep going, putting more and more of these things going up, one about every clock face, as we said. Let me see if I didn't get a picture of the final, but you can tell that was going to be a robust repair. I think it's important to say that open Bankart is still the gold standard. There's no such thing as always and never, but open Bankart is still good. I typically use open Bankart repair for high contact athletes, rugby, football, wrestling, some basketball, or if something has failed, what I consider to be a well done arthroscopic repair with minimal bone loss. So, there's a lot of good surgeons and a lot of good repairs, but if somebody has failed a good repair with good fixation, I'll do an open Bankart. That's a great operation. We use a standard delta pectoral approach, multiple all suture knotted or knotless anchors. I usually use knotted anchors when I'm doing them open. Again, one for every clock face. It's still okay for minimal bone loss. And I would say right now, minimal for me is probably 15 to 20%. But it depends on where the bone loss is. If the bone loss is truly inferior, those don't do as well as if they're kind of in the mid portion of the glenoid. I prefer to split the subscapularis, but taking it down is okay. And repairing it does slow them down a little bit, which is sometimes a good thing. So I certainly don't mind doing a subscap dissection. My number one indications for arthroscopic repairs are overhead athletes. So you avoid the anterior dissection, you avoid the rotation limits, and the anterior subscapularis and things like that, issues that overhead athletes simply do not tolerate. So I do like doing them arthroscopically whenever it's possible. Here is another one. So this is one that's a much bigger injury. This person has a big anterior labral tear, but they've also got a large Hill-Sachs lesion. So what you're going to see here is this big anterior labral detachment, a lot of pathology, a lot of injury, and this huge engaging Hill-Sachs lesion. So we're going to do an anterior labral repair here. We're going to, have had this big tear. So we're going to put lots of anchors in here. I'm going to advance through this. We're going to have, a bunch of anchors up the front and really get this thing tied down. But the interesting part about this case is how we handle the posterior side. So once we get this thing all tied down, he's going to have a pretty stable look on the front. We have to actually go to the back here and do some more. He's got such a big tear, we had to go front to back. And so really big injury. But now when you look at the back side of this guy's shoulder, he's got this huge tear that has this big Hill-Sachs lesion. So I'm going to show you this Hill-Sachs lesion here. Look at the size of this thing. This is going to engage. This is called an on-track lesion. This thing engages when his arm's in about 30 degrees of external rotation. So I've already sewed down the front, now I've got to address this. There are several options for addressing this. We can put plugs in here to avoid having to do a remplissage. In contact athletes, I like doing a remplissage, so I'll use two all suture, what are called FiberTac RCs. These are 2.6 millimeter anchors. They're double loaded, and I'll usually use two of them. I put one in this one, and I put another one in later. But I'm going to show you the first part of this. So I'll use a passer. I'll pass a wire in there and grab it through, use a bird beak or something like that to grab the suture through the capsule. So I'm going to grab my sutures out. I want the one that I'm going to grab there. And I'm going to just do a little twist here and grab that suture. And I'm going to be able to pull the suture through the capsule where I came in with my passer. So I'm going to do that 4 times for this particular anchor, and then we're going to sew it down, tie it down. So I'm pulling the capsule up here, and you can see the effect is to posteriorly translate the humeral head. So now I've posteriorly translated the head, which aids in the stability of this operation. So I've got a big anterior repair and a remplissage. And yes, this person will definitely lose some motion, but in a contact athlete, I can certainly tolerate that. So this is now got this guy in a good position. He's not going to engage. He's going to lose some external rotation. So there's a big anterior repair there. So what about capsular plication? This is another thing that's become popular. I think capsular plication can be a good thing. I think it can also be a dangerous thing. This is obviously healthy looking labrum. There's no labrum detachment here. This person doesn't have any real pathology in terms of labral tearing. The glenoid looks good. The surface looks good. There's no real pathology. It's just loose. So this is a looseness operation. This is a laxity operation. When we think that the laxity is the problem, if I look down inferior, you can kind of see the capsule's a little translucent. So this is kind of a stretched out or an advanced capsule. So I'm going to place an anchor this is a knotless anchor. I'm going to place it right on just at the articular surface. I'm going to pull up some capsule here. In this case, I want to take more capsule. I'm trying to decrease rotation. So as opposed to a thrower where I really don't want to do that too much, in a non-thrower or somebody with this much laxity, I really do want to pull it up. So again, this is that knotless anchor. I'm going to pass it outside the shoulder. I'm going to pass the suture in the loop and then pull it through. And by doing that, I get my knotless construct down there. And then I'm passing the suture through the loop there. We'll pull it through and advance the knot down. And this is going to give me a very nice tight repair of this capsule back. And I can go on and put 3 or 4 of these things in there. And I'm just going to advance to later in the procedure here. But I can put these at multiple clock faces and really tighten this up good. These are really easy to use. They hold really well and they're really small, which makes it great for putting in lots of points of fixation. So what about bone loss? A lot has been made and researched about bone loss in the last 10 years in the setting of shoulder instability. We know that successful stabilization in the presence of bone loss is complex, and preoperative planning is where it's at. So CT scans, things like that, to determine how much bone loss, really understand how much bone loss is there and how much is acceptable, what procedure is best, and adjuncts like remplissage and things like that when necessary. This is a big topic that we could spend days on, but the long and short of it is that you have to look at the on-track, off-track Hill-Sachs lesions. The off-track are less likely to engage. There are different bone augmenting procedures. The Latarjet is certainly the most popular. I prefer the distal tibial allograft. I'm not a fan of Latarjet. I usually have 3 or 4 times a year, I have to revise a Latarjet for things that didn't heal or screws that are out of position. I've seen some neurovascular injuries with that operation, so I've never done one. I don't like that operation. I know it's popular, but it's not my preference. I do like distal tibial allografts. I think you're restoring an articular surface with a cartilage presence, and it's simply just a bone restoring procedure. It's more expensive, but it's less invasive and less problematic from a complication standpoint. So it's important to consider these options and know them. If you're going to be a shoulder instability surgeon, you have to be able to deal with these kind of bone loss issues. All right, so briefly in the last few minutes, we're going to talk through some simple things. Spinal glenoid notch, paralabral cysts, these are pretty big. This is after a month after we did an aspiration and a cortisone injection. The cyst is back. This is a big one. This guy had weakness in the infraspinatus, secondary to compression of the suprascapular nerve. Oh no, my video is not going to work there. Nope, the videos aren't going to work on this one. Gosh, I was batting 1,000 with the videos. That's too bad. Posterior glenoid exostosis throw. This is an exostosis on the thrower. You can see this in the West Point view. Let me go back to doing the spinal glenoid notch. So even though you can't see it, these are really easy. You make a 1 centimeter incision superior to the labrum in the capsule in the recess, and basically from there, a standard anterior and lateral portal, or maybe an accessory portal with a small shaver. You can put the shaver and the scope right into the cyst and trim them out directly under direct visualization. So the thrower's exostosis, this is an exostosis. You can see it on the inferior posterior glenoid. This is the West Point view, which makes it easier to see. These are typically thought to be traction spurs on the posterior inferior glenoid associated with a pull of the posterior band of the inferior glenohumeral ligament. People usually hurt during the deceleration phase of throwing, and they're not always symptomatic. This would be a pretty big one. You can see them on CT scan here. This is a pretty large Bennett's lesion. When people have posterior pain in throwers, this is one of those things you have to think about. We like to think about rotator cuff and labrum because they're common, but throwers exostoses are actually pretty common too. Oh my gosh, it's not going to show it. So this was the pre-op x-ray. I'm having some technical issues. I have to fire my audio-visual guy. So this is our post-op x-ray. We were able to take this off. Again, a 1 centimeter incision in the posterior capsule right off the glenoid. We do not repair the capsular tears in these in the cyst or the Bennett's lesion. It's very important. These people typically do not have labral tears, so that the incision is in this heaped up tissue posteriorly that that you just want to cut through, and you're right down on the exostosis. So it's about 1 centimeter off the joint and direct to it with the posterior portal with a shaver. An OCD of the shoulder. These are really kind of interesting problems. If somebody has joint pain, even moving towards the back, these OCDs are always in the same place. They're always in the mid portion of the glenoid posteriorly. They're never anteriorly. They're kind of typical for OCDs, like in the knee and in the ankle. You see them in the same place, which makes you think this may be a vascular insult in the glenoid. And these are big. They're usually 1 centimeter square plus. And taking them out and just doing a microfracture is usually the answer. Gosh, the videos are there, but they're not running. Awful. There's what it looks like at the end after you take it out and do a microfracture. So we've got these, you want to get some bleeding in the shoulder. And we've made some microfracture holes. Maybe I can go backwards and see this is taking the piece out. So we've got that piece sitting there. So I'm going to go back to the glenoid OCD here, or the Bennett's lesion, and see if I can back into some of these. Yeah, so here's where we start. So taking this out, you can see the labrum is actually not detached on the glenoid, on the Bennett's lesion. And so you're just going to make a little incision just past posterior to the shaver to take that out. So now I'll go back forward to the next topic. So clavicle fractures. We previously treated clavicle fractures non-operatively. When most of us trained, we treated these things non-operatively, and the outcomes of surgical management were no better than non-surgical. In the last 10 years, a lot has happened, and these bone-specific plates and plating systems have gotten better. And now the outcomes of surgical stabilization are actually better than non-surgical treatment for displaced fractures. A lot more rapid return to function, to work, to school, to sport. We get early range of motion. All of our shoulders go to therapy the day after surgery, regardless of the procedure. They get pain relief quicker. Most clavicle fracture patients will tell you they feel better in the recovery room than they did when they went to sleep, which is kind of strange to have surgery and feel better when you wake up. So most displaced clavicle fractures are now treated surgically in the athletic population. My preference is the Acumed system. These are bone-specific plates. You can do locking and non-locking screws. The plates are contours, about 7 or 8 different plates. You can go anterior, you can go superior, you can do both. These are very simple operations that are low risk. We start range of motion immediately. We use a sling for exercise. Usually they're doing cardio when their wound is healed, and non-contact sports as soon as 2 weeks post-operatively, and contact sports at 6 to 8 weeks post-operatively when there's bony union. The bottom line is that the plate bone construct is stronger than normal bone. So we published on this in 2013. We had 30 athletes. 67% of them returned to play in less than 12 weeks, and 23% of them returned to play in less than 6 weeks. The range was 12 to 277 days. So we had a college football player go back in 12 days as a running back. So these are very strong constructs, and they do very well. And lastly, what about AC joints? There's not really been much change in the approach to AC joint injuries. Types 1 and 2 are treated non-surgically with rest and gradual return. Types 4, 5, and 6 are treated surgically with either acute repair or CC ligament reconstruction. And type 3s continue to be in the middle. For low demand patients, we usually treat them non-surgically. Rest, sling, physical therapy, and a gradual return. And if they have symptoms, we'll do a CC ligament reconstruction if symptoms persist. In the higher demand patients, you may be better off with surgical management acutely. This is a dog bone type of construct where we're doing this. We can do this arthroscopic assisted. There is definite considerable improvement with the use of the dog bone type repair over open graft reconstruction. We're basically just putting it back where it came from and allowing that tissue to heal. These constructs do not create great stability in the anterior to posterior plane, but they do create great stability in the superior to inferior plane. So to conclude, surgical treatment of the athlete's shoulder is really focused on instability and rotator cuff and labrum pathology, but you got to be aware of some of the lesser causes of symptoms. We have definitely moved to soft anchor technology with basically better pullout strength. They're smaller. And in my world as a fellowship director, I say they're fellow proof, which means if I don't like where the fellow put it, I can drill through it or put another one. We're using knotless anchors whenever possible throughout the body. The ankle, the wrist, my partners that do all these things are using mostly soft and knotless anchors when they can. We're doing a lot less slap repairs in non-overhead athletes, a lot more biceps tenodesis. Again, we're doing those high in zone 2 using a mini open sub-pec approach. And we're doing more bone augmenting procedures. I actually think these are being overdone. I think they should be used for bone deficiency, not for simple primary instability, because the risk and the complication rate is just higher. So with that, I'm going to say thank you. I have had the opportunity to treat all 4 of these guys, one of the Singh brothers, Harv, and have really enjoyed them. I look forward to coming to India with WWE, but also hopefully to visit your beautiful country and sometime get the chance to meet you in person. Again, I'm honored to have been invited, and I look forward to any comments or questions. This is our team of fellows that just graduated and went out across the country to take jobs about a month ago. And I get the great blessing of parenting 6 new ones every year. So again, thank you very much for the opportunity, and I look forward to your questions.
Great. Thank you very much for that nice overview on this extensive topic, Jeff. That was quite well done in time. So we'll just open to questions. Dr. Maheshwari, you have any questions? We'll start with you first.
Yeah, informative lecture, very comprehensive overview. My query starts from making a diagnosis. Now, often not the throwers, basically these are cricketers. Complaining throw it with the full power from the boundary, and the strength of throwing is reduced. You examine, you find nothing positive. You do an MRI, you find nothing positive. And then you are lost what to do with them. You do send them to rehab, 6 months, nothing happens. And not what to do with them. And for some time, I started doing arthrogram, but my radiology colleagues lately have started telling me that with 3T, MRI, probably need to do an MRI program. So this is the point where I'm stuck very often. When patient has a throwing problem, he has pain in throwing, he has no power of throwing, I have no clinical findings, I have no MRI findings. Where do I go from here?
So that's a great question. Basically, the no finding thrower with shoulder pain. So I would say that most of those are going to be anterior shoulder pain. So I always like to ask them, what part of the throwing motion hurts? Is it more at ball release, or is it more at the late cocking, early acceleration phase? And most of them are going to point to that anterior triangle where the biceps comes out of the shoulder as the source of their, or the location of their pain. I think this is a great place for diagnostic injections, ultrasound guided diagnostic injections. I don't know how to turn our ultrasound machine on. I've never used one, but I've got a bevy of people that know how to do that in my office. We've got all these guys that are great with the ultrasound. I call them the needleists. Their whole job is to stick needles in things. And so I get one of the needleists to inject this starting in the joint. So I want to start intra-articular and see if I can get their pain to go away with just some Marcaine or Neuropin or something, a low dose, to see, does that relieve their symptoms? And we have a lab next door where they can go throw, and I can get a feeling for that. And I'll do a bicipital groove injection and see if that relieves it. Or I'll switch the order if I really think it's biceps. I think the biceps is a lot of the problem in these people. And that tells me that they're having some kind of mechanical dysfunction from a throwing perspective. I think a lot of what you're describing is mechanics, and it really can be solved through scapular positioning, scapular improvement, really honing the medial border of the scapular strength, really working on their trunk, their hips. They have some kind of dysfunction that's protracting their scapula in the throwing motion. And it really starts from the ground up. So this is where having my biomechanists really look at their body as a whole, because they're having shoulder pain, but they don't have anything pathologic, really evaluating their body from the floor up as they throw, and then doing these selective injections. So one of the things that I'm looking for is it truly biceps pain? You know, are they having biceps tendonitis that they can't get rid of? And those are the ones that I think we got to be real careful with. If you're going to tenodese a thrower, that might be the one to tenodese. But again, you're potentially creating some problems by drilling that hole in the humerus. I've gone to using a smaller anchor rather than doing the 5.5 millimeter hole and dunking it in there with a screw. I've gone to using those small all suture anchors, and I'll use 2 of them separated by about 1 centimeter in the bicipital groove, so that I'm not creating a stress riser in the humerus and a thrower. So you're describing a lot of people that we all see. That's a very difficult question, and a great question, because it encompasses so many people we see in our offices. But I would tell you that the biomechanical evaluation of floor to shoulder is important in those people. And this may be something in their hips or their legs that's causing that.
What is your threshold of doing arthrogram when you have 3D CT available, 3D MRI available?
So we have 3D, you know, we get MRIs from everywhere. So we're not usually the ones ordering the MRI. So the way insurance works in the United States is you typically are not going to be able to get a second MRI unless there was a problem or they got a poor quality MRI. So for us, we get a lot of MRIs from a lot of places. I call them strip mall MRIs, where somebody stuck a magnet somewhere and it's some poor quality thing. We get a lot of those. And when I see those, it's hard to read those, and they never are contrasted. So when they come to us and we order an MRI, we're ordering contrasted MRIs on a 3T magnet all the time. Our radiologists prefer that from the standpoint of their ability to read it. I think you're correct. I think good 3T imaging with good musculoskeletal radiologists, you don't need the contrast. Hollis Potter and I, we argue about this all the time. Hollis will tell me she never uses contrast, and she's the best I've ever seen. Not all radiologists are equal. So, you know, and I'm certainly not a radiologist. So I think that from a contrast standpoint, my radiologists seem to like doing it. I think with good radiology and a 3T magnet, you probably don't need it.
Thank you.
Jeff, along the same lines, just wanted to ask that obviously certain centers and certain countries prefer MR arthrogram or CT arthrogram versus 3T MRI. I think in India, we prefer a 3 Tesla MRI. So my question to you along these lines is that would it be more appropriate to use an MR arthrogram in chronic injuries and in a patient like what Dr. Maheshwari mentioned that, you may suspect something in the joint, but you're not able to pick up on your tests and your regular MRI scans. Would MR arthrogram be a better option? What are your views?
So I like it particularly for the patient that Dr. Maheshwari described, because I think you see some subtle findings in the bicipital groove that the contrast enhances. You see this kind of almost synovitis in the bicipital groove a little bit if you really focus in on it. So I have seen that, and I do like the contrast in those. The other thing about the contrast is I can throw a little cortisone in the contrast, and maybe that's therapeutic. I can throw a corticosteroid in there if I really think they have something that's inflammatory in nature. The only thing I'd say about corticosteroid, I'm not a big user of corticosteroids. If I end up having to repair something, now I've put a corticosteroid in there, have I impeded the healing potential of that tissue? So I don't like using corticosteroids if I know I'm going to be operating on somebody and I'm doing the MRI just to have evidence or get a good look at something. So I think judicious use of corticosteroid in those injections can be helpful.
Great. IPS?
Yeah, so there is a question here. It says that a couple of these throwing athletes have a posterior inferior labral tear. So it's essentially a posterior instability. And when you fix them up and rehab them, ultimately by end of 8 to 9 months, they start having some anterior shoulder pain. So how is it the kinematics are different, or are we over tightening posteriorly? How does that happen?
So Kevin Wilk is the therapist that he works downstairs from me. And I will say very loudly that my success in terms of clinical outcomes, I have to give Kevin a lot of credit. He's world-class and has done much to train the therapists of the world. So I benefit from Kevin's knowledge every day. Kevin has a lot of thoughts on this. I think that when you repair the posterior labrum, you're pushing the humeral head anteriorly. Now, they may regain their motion and they may regain their capsular compliance, but that anterior pain is likely a stress from that more anterior positioning from the posterior repair. So basically what didn't happen is they didn't get their capsular stretch back posteriorly, and the posterior repair is still pushing them forward, causing them anterior pain. So it becomes a capsular mobility thing. That's something that Kevin would spend a lot of time stretching the posterior capsule and really doing posterior capsular mobilization to decrease the anterior pain. He believes very firmly, and I agree with him, that the repair, if it's good, can tolerate that really strong posterior stretch, that cross-body stretch, that posterior capsular mobilization to get that stretch back and relieve that pressure on the anterior side. And so he would tell you, and I agree, that posterior capsular mobilization is the solution to that anterior problem.
Great.
How fast after the posterior repair would you start that? How early after the posterior stability would you start that?
I'm sorry, I missed the question.
So I said, how much later after the surgery would your physio actually starts the stretches? So it is 6 weeks, 8 weeks, 12 weeks later.
So when we do a posterior operation, we're typically putting them on posterior precautions, which means no cross-body adduction, no internal rotation for 6 or 8 weeks until the healing process is complete. And then we will gently try to regain their normal motion, at the side and a little bit of abduction. I would say we're really starting to stretch the posterior capsule somewhere around 3 to 4 months. We'll be doing some plyometric drills at that point, and that's when we can really kind of gently stretch that posterior capsule before they start throwing, especially. So if they're a thrower, you don't want them to throw until that capsular compliance is back to normal. But I would say to really get them to lay on, Kevin probably would not tell anybody to really lay on that posterior capsule to stretch it until at least 90 days, maybe even 120 days. you know, the capsule will get its compliance back. You just have to give it time. So making sure that the healing is done, I think is right.
While we're talking about the posterior labrum and in looking in terms of the peel back mechanism causing injuries in these throwers, is it correct to say that when we repair the slap component, it's important to put the posterior superior stitch and anchor, but ignore the one anterior to the biceps root, because that may prevent them from their external rotation mechanism?
It is. And in the video I showed, I put one or two up there in the front. That was an old video. That video was probably 7 or 8 years old. I think not putting those anterior anchors up there is very important. I think what it speaks to is not to constrain the biceps. You know, as we throw, the rotation of the humerus is pulling the biceps posteriorly. There was a biomechanical study I think we did back maybe early mid 2000s. We could not create a slap tear with longitudinal traction on the biceps. We tried and tried and tried, and we couldn't create it in the lab. The only way we could create a type 2 slap was to pull the biceps posteriorly. So as the greater tuberosity, as the tubercular groove pulls the biceps posteriorly in external rotation, it's that back and forth motion, like you're pulling a weed out of the ground, that causes that detachment at the superior labrum. It's not distal traction on the biceps. So if you can't rotate back, if you can't pull it back, you're going to have a problem. And I think that's what that anterior anchor really does. I think it probably limits the biceps' ability to translate posteriorly or rotate posteriorly. And that may be how we over tighten those things. And so we've kind of gone away from putting that anchor in the front of the biceps. You're exactly right.
Great. Sundar?
Yeah, my question is on the partial tears. I want to know whether do you operate all partial articular sided tear which are found in MRI in all athletes, or do you have any specific clinical finding which you can correlate so that this patient needs surgery for this articular sided tear?
No, the great question. I definitely do not. I would do anything I could to not operate on partial tears. Partial tears are kind of the nemesis of the shoulder surgeon, in my opinion. I think the outcomes are not great. I want them to fail everything under the sun before I operate on them. We'll do PRP, we'll do all kinds of extensive rehab, change their mechanics, anything I can do, because I think the outcomes of those things are just not great, especially in the overhead athlete. Operating on the rotator cuff of an overhead athlete is just never a good thing. So the woman that I showed you, the 39-year-old, she did 2 years worth of rehab and finally talked me into doing it. So no, I want to avoid operating on those whenever possible. I think 20 years ago, we probably overdid those operations in terms of what we were trying to accomplish. I think minimalist approach in those cases is probably becoming more important. But I still think they're not great operations. That kid that I showed you, the 14-year-old with that big posterior tear, I do not think that kid is going to come back and be a great thrower. His father thinks he's going to be a great thrower, but I do not think that. I think that kid is going to struggle to have a career in throwing.
So Jeff, talking about these partial articular sided tears, obviously in the non-thrower population, we follow the 50% rule. Would you follow that in that kind of a patient cohort as well? Not talking about the throwers.
Yeah, in the non-thrower, I do. I think that, you know, the cuff tear is going to progress, right? I mean, we know it's going to progress. And so I always have a very direct conversation with the patient that, look, it's a question of whether you want to fix the problem now or you want to fix a bigger problem later. So my words to patients are, don't treat the MRI. First of all, I tell the fellows always, don't treat the MRI, treat the patient. And if they're annoyed by their shoulder, but not really limited by it, I'm not sure I'd have an operation for annoying. But if they're limited by it and they can't do the things they want to do, they can't enjoy their jobs or their fun or their activities or their athletics, then I would go ahead and do it if they failed a non-surgical treatment, knowing that it's going to get worse with time. So I think that there are people that can function with high-grade partial tears. Half of the Hall of Fame of baseball has a big, you know, their shoulders look terrible. So, people can function very well with high grade tears, but if you can't function, if the pain is great enough that it's keeping you from enjoying your life, then certainly fixing it is reasonable.
And talking about yes, Dr. Maheshwari, yes.
Yeah, sorry. So my question is regarding plication business. So very often we have these patients who are painful, unstable, but they don't have a clear-cut Bankart lesion. And after having tried a reasonable period of rehab, you finally decide to go in. And then you find, as you showed one of the case, and you seem to think that it is all capsular stretching problems. And then you try to, placate it. Now, I want to know from you, what is your trick or tip of placating those shoulders? Because I'm never sure whether I'm overdoing it, underdoing it, will it cut through later on, or what will happen? So, tip on that.
So the question is about, how much to plicate, right? It's the universal question of how much is tight enough or loose enough. I think that first I'll say that I think MDI, multidirectional instability, is not a good operation for the scope. I've been impressed at how poorly people have done with global MDI, with inferior components, and people with Ehlers-Danlos and things like that. That's an operation for a capsular removing procedure like inferior capsular shift with the T-plasty that Alchek described. I still think that's a great operation where you're dialing out volume of the shoulder. And those people do very, very well and with stable shoulders for long periods of time. I don't think the scope is a good way to do that. But when I'm dealing with just capsular laxity or acquired capsular laxity with no labral pathology, no capsular tear, nothing like that, I typically like to do 1 centimeter bites. Like I showed with the anchors, I like to use an anchor. I don't want to just sew it down to the labrum. So I do like using an anchor. I'll usually do 1 centimeter bites, and I like to put 3 anchors on the back side if I'm on the back, 3 on the front if I'm on the front. I think multiple points of fixation are important. I have seen people tie down Buford complexes. I've seen people tie down, the middle glenohumeral ligament. I've seen all these kind of things that we have to try to undo. So I think that capsular plication is one of those things that is not a very difficult operation to do, but may in some places have been overused by trying to tie things down. I think that, again, 1 centimeter bites, I think are the way to go. And I would rather put another anchor with another 1 centimeter bite than put 2 anchors and do a 2 centimeter bite. So I think it's more of just
kind of ripstop kind of suture.
Do I what?
Out some kind of a ripstop kind of a suture to prevent the capsular, cheesing out and cutting out.
I use a tied, we tie the anchors on those. So when we're doing, we use the knotless anchors usually for those. You can use a tied anchor on the back side of the capsule. So a lot of times I'll use a cannula through the deltoid and tie on the back side of the capsule or the front side of the capsule. So again, I think the point being multiple points of fixation. I think I don't like using double loaded. So I will not use a double loaded anchor on labrum or capsule. I've used only single loaded anchors in those settings. I think if you're double loading those things, you're probably creating too much stress at one point and trying to pull everything to one spot. So I want to use more points of fixation and smaller anchors.
Yeah, Jeff, you mentioned quite an important point that studies have shown that capsular plication, which is anchor based, is better than what is labrum based. Now, this new concept which you all just quoted, that multiple points and more anchors, because conventionally we've been taught that, you place the anchors maybe a centimeter and a half apart. But now I've heard someone else mention this as well, is that, the more the anchors, the better. Is this because we are going smaller in terms of the anchor diameter, or is it that we are trying to make a more robust construct?
Yeah, I think it's both, Shreyash. I think it's because we can go smaller, we're down to these 1.4, 1.5 millimeter anchors. Is it more robust healing because we're getting a better marrow access? You know, we're effectively microfracturing the glenoid, you know, at that point. So we're getting lots of marrow content. We're getting a better healing response, probably. We're getting better compression. It's similar to the difference between a single row or double row rotator cuff, right? We're getting more compression of the tissue on the face of on the surface of the side of the glenoid, the neck of the glenoid. I think it's also enabling us to not have to pull up giant bites of capsule if we're just trying to stick it back. So, you know, it gives us a more robust construct. I know the anchor companies love it, but that's not the point. You know, it's, you know, we want to make it sure that they heal. So I have the blessing of working in a hospital setting where nobody tells me how many anchors I can use. If I'm working in a surgery center, a lot of times they'll tell you can only use so many implants, which really limits things. So I'm not constrained by that, which I think definitely changes the outcomes spectrum.
Also, it's good to know from you, because you guys are doing large volumes in your center for an all suture anchor, because it's just been introduced in India. And especially me, I was a little apprehensive how that would behave, but kind of you have reassured us saying that it really is doing well. Even on the rotator cuff side, I believe you guys are using a lot of all suture anchors. So that's something good to know.
We've really moved towards, and I mean, I'm a consultant for them, but we've really moved towards the Arthrex all soft anchors. They have really, the science that they've really come with, and the multiple options and different suture types and colors. And I think they've made it easy. They really are a very agile company in terms of what they present. We've all moved, a lot of us, a lot of the shoulder and elbow guys around here have moved to doing those kind of things. The knotless stuff keeps getting better. In the UCL and in the internal brace stuff that I'm doing, we're working on an all soft anchor version of that. We're doing rotator cuffs with these things, ligament surgeries, ACL repairs with all soft anchors. I mean, all kinds of things.
IPS, did you have any?
Yeah. Jeff, in the case of a badly done slap, slap repair, the patient ends up with a stiff shoulder, unable to throw now. How can you undo these issues now?
Yeah, those are really hard problems. I think you got to go in there. If they're stiff, you want to, you know, get a good exam under anesthesia before you put the scope in. Get the scope in there. Definitely tenadese, you know, remove the biceps. You got to tenadese them. I would be careful in the thrower. I like I said, I'm using the smaller anchors, not the screw. I want to stay way up in the groove, not in the diaphysis. And really, I would also go subacromial. I think some of these people get some real subacromial scarring. Some of that loss of motion can be extra capsular or extra articular. Sometimes it's not, but I think you're there, so you got to look for it. Maybe they've got some deltoid scarring or something. And really, you know, when you've seen people tie down the Buford or the middle glenohumeral ligament, you just got to release it. And I've seen people get their motion back with that. I caution them that, you know, they're in a bad spot anyway, right? I mean, they can't throw, so what do they have to lose? But I think that it's those are bad actors, but I have seen people come back from that. But I think that the tenodesis is important. Getting that biceps out of there is important, and then releasing everything they fixed. In
terms of the instability, you very interesting to hear your.
Just a question.
Yes.
Yeah. Though it's not a part of exactly your topic, but the question here is recurrent sternoclavicular subluxation. Have you seen these cases and operated these cases, especially in throwers? The moment they throw, they just subluxate their sternoclavicular joint.
So I have seen those patients. I wish that somebody would become a sternoclavicular expert so I could send those patients to them instead of them coming to see me, because they're not fun patients to see. I don't think that stabilization of the sternoclavicular joint has had great success. So the way I have dealt with those is to do a distal clavicle excision arthroscopically, similar to what we would do for a Mumford or just an arthroscopic distal clavicle excision from the subacromial space. That way the person cannot come across and compress their AC joint and create the stress at the SC joint. So I'm dealing with that problem at the AC joint and eliminating the ability to kind of cam and pinge over and create a problem at the SC joint. And I've been happy with that. I know I'm not directly solving the problem, but I'm eliminating the ability to compress and sublux the SC joint by taking out the distal clavicle.
That's clever.
Another important thing to note from your talk was that in the contact athlete, in the absence of subcritical or minor bone loss or no bone loss, you mentioned that you would go in for a repair rather than a bony type of procedure. Now, what is your threshold of adding a remplissage, and how do you decide?
So I typically want to know how big I want to see the Hill-Sachs lesion. I've got a CT scan usually in these people, especially in contact athletes. I've gone to doing CT scans preoperatively in a lot of these people so that I can know what their glenoid bone looks like, as well as what their Hill-Sachs lesion looks like, and measure the kind of on-track, off-track degree. My sense is that is really an operative decision. So I consent these people for possible remplissage, but I really make the decision in the operating room. I think we can get fooled radiographically sometimes by these things. So as much information as I can get preoperatively, I still make the decision intraoperatively. I think if I'm dealing with a non-thrower or a contact athlete, I have a low threshold for doing a remplissage. I've not had a patient yet, knock on wood, I've not had a patient yet that I've thought, man, we'd be fine if only I hadn't done the remplissage. But I've had a couple of patients that I think, man, I would be fine if I had done a remplissage. So I think that I'm more likely to do it in the presence of a contact athlete, especially with an on-track lesion. I think that it's one of those things that I don't think it negatively impacts the outcome. And I think you got to be careful not to overdo it. I think, trying to get that capsule all the way down to the articular surface is probably overkill in some of these people. What you're really looking for is just a posterior pull. So I've been happy with that. I would say that I don't do them very often, one a month, one every 2 weeks, something like that. So not a big number, but I have been happy with the adjunct of that to the augmenting or doing something anteriorly.
Okay, great. Any other questions from the panel? If not, we can conclude.
No, I think that is okay. Shreyash, it was wonderful. So if you can conclude, please.
Okay, great. Really, it was a very insightful and talk on the topic, where we've learned that in the athlete, especially the overhead athlete, less is more. And on behalf of the Indian Arthroscopy Society and personally myself, I'd really like to thank you for again agreeing to participate. And certainly, as you mentioned, we look forward to an opportunity to host you and see you in person. Thank you very much.
And you as well. Thank you guys very, very much, Dr. Oberoi, and all of you. Thank you. And obviously, if you find yourselves in the United States and you're anywhere around, please don't hesitate to reach out. We would love to host you. And I wish you all the best. Stay safe. And again, thank you for the kind invitation.
Thank you. Thanks a lot. Thank you. Bye.
Thank you very much. Friends, in continuation with our webinar series, our webinar number 99 is on return to sports after knee ligament injury. And we have a master on that, the consultant knee surgeon, Dr. Andy Williams. Dr. Andy Williams is a very popular name in India. He has operated on many of our national cricketers. Andy is placed at London, and he is associated with the Imperial College London. Return to sports after knee ligament injury would be an interesting topic. We all are doing a lot of ACL reconstructions, and I think he will help us solving this dilemma. Do tune into Indian Arthroscopy Society YouTube channel on 9th of October, Friday at 6 p.m. for this interactive webinar. And thank you very much for joining it today. Thank you, and take care. Bye-bye. Thank you, Jeffrey.